NICE, which has been issued, which says giving birth is safer at a midwife-led centre or at home rather than in hospital. Health advisory body, the National Institute for Health and Care Excellence, NICE, said the latest evidence shows women with a low risk of complications are better off staying out of the labour ward, warning that doctors are actually more likely to make interventions such as caesarean sections. Let's have a look at some of the statistics that swirl around this. Midwife-led births still make up the minority of the 700,000 babies born in England and Wales last year. 9 out of 10 arrived in hospital, ultimately under the care of an obstetrician. But with 45% of women at low risk of complications, 315,000 would now be adjudged safe to give birth at a midwife-led unit, or indeed, if they so chose, at home. So today on the Sky News Debate, we're asking, where is the safest place to give birth? Joining us now to discuss that, Dr. Daghni Rajasingam, who's a consultant obstetrician, and Rebecca Schiller, who's a birth doula giving support to new mums. She's also the co-chair of the Birthrights charity, which promotes rights in pregnancy and childbirth. Before we get started, though, a reminder you can join in too with our debate. Tweet me at Colin Brazier Sky, or Sky News, including the hashtag Sky Debate. Text on 84501 or email news@sky.com. Do let us know what you think, and if there are any suitable junctures, we'll try and introduce some of your comments to our guests and reflect on those. Before we start, Rebecca, just to help us with doula, a lot of people know what it means. Some people will be scratching their heads thinking, what on earth is a birth doula? You are one. What does it mean?
Well, it's a very ancient role, really. We are non-medical birth companions, so I work with women during their pregnancies, helping them feel prepared, and then I actually go with them when they're in labour. I stay with them during birth, providing all kinds of support, and I come back afterwards when they're scratching their heads and wondering what to do with the baby. OK. Daghni, you are a health professional. This report comes from the National Institute of Health and Clinical Excellence, not from a one-man band campaign group or some flaky charity or anything like that. You know, this is NICE who is saying this, therefore we must take them at their word. What do you make of what they've had to say?
Well, we welcome the guidance, actually, within the healthcare scenario and maternity services. The guidance has changed a little bit from the previous guidance that was issued, but it is based on evidence. It's a group of healthcare professionals and lay people who advise on how the guidance should be worded and what should be recommended. So we welcome the focus on the woman and her family. We welcome the focus on choice, respecting the woman, and we also welcome the reiteration of the importance of one-to-one midwifery-led care during labour. Are
there any circumstances, though, Doctor, under which you, either you personally or through the recommendation to your friends and family, would say, OK, home birth, good thing? Would you do it? Would you recommend to friends and family that they do it? How does it apply to you?
The important thing about home birth, and in fact for where women choose to have their babies, is that they are risk stratified. So this means things that might make your pregnancy a little bit more complicated or not, as the case may be. So for low risk women, especially women who've had babies before and had them safely and without complications, delivering either at home or in a midwifery-led unit, which might be freestanding, so it may be outside of a hospital environment, or might actually be within a hospital environment, are safe and could be recommended.
Didn't quite. Can you answer the question, though, Daghni? You know, if you had to make a choice personally, or you were candidly advising a loved one, what would you advise?
I would advise them based on the statistics and the recommendations. So if they had had a baby before, it is perfectly safe for them and their babies to have a delivery at home or in a midwifery-led unit. Now, what is important is what most women perceive as being safe. And there are a group of women who feel that delivering in a midwifery-led unit with all the benefits of having midwifery-led care, one-to-one care, without obstetricians necessarily being there the whole time, but having quick and easy access to them would be their choice.
Yeah, Rebecca, we come to the numbers thing here, don't we? Because we talk about low-risk mothers. Many of us draw on our own experiences. My wife had 5 successful pregnancies. She had 5 children. Along comes number 6. She's desperate throughout the whole process to have a home birth, give birth in her own bed. And her husband, me, digs his heels in and says, no, look, the risks are too high. Number 6 comes along. It's shoulder dystocia. He's stuck in the birth channel. Had she got her way and we'd been at home, He was Apgar 1 on the scale. He was nearly dead. He probably wouldn't be here to this day. The fact was, we were in a hospital with all the medical facilities on hand. There was a crash team. A team bundled him in. He was in an ICU unit for a while afterwards. He's fine now. Had it been a home birth, he'd have died.
I'm very sorry that you had that experience, which sounds incredibly traumatic.
My point is, we couldn't know it was low risk.
No,
she showed no risk complications.
I understand your point, and I think that's why it's important to return to the evidence, and why NICE make it very clear that when healthcare professionals are advising women based on these guidelines, they have to look at that evidence and actually remove their personal feelings and personal prejudices. These guidelines are very explicit about that, because when you look at the evidence, it shows very clearly that on these very big, very robust studies, as Daghni said, it is very safe for low-risk women, particularly those who have had a baby before, to give birth at home. Now,
but Rebecca, my wife had lots of babies before, but you can't predict. Shoulder dystocia is not a very exotic condition during pregnancy, during the process of giving birth. But you can't predict it. You just can't predict it.
No, and you also can't predict the instances in which a woman who is low risk, who would be giving birth outside of a hospital, if she was inside a hospital, the system there, the interventions there would actually make that pregnancy more complicated, that birth more complicated. We know that happens because if you take the same low risk woman and she gives birth at home, her chance of having an intervention, even if she transfers into hospital, is at around 10%. If she goes into hospital, that increases by 35%. Now you have to look at what that means for a woman. A cesarean section and episiotomy, a forceps delivery is not a small thing,
and
for no increased benefit to the baby overall.
But isn't the point, Rebecca, that it's not fatal? I mean, nobody wants to go through those things, as you quite rightly point out. Nobody wants a forceps delivery. Nobody wants a C-section if they can possibly. Well, some people do, but they're not fatal. Those interventions are troublesome and painful and awkward, but they're not fatal.
We have to trust here that women are able to look at evidence and to make decisions based on that evidence. This ultimately is a woman's decision to make, and what I like about the NICE guidelines here is that they're giving women the chance to examine the evidence themselves.
Is it just a woman's decision, really, Rebecca? I mean,
of course it's just a woman's decision.
Well, you say that, but my wife wanted to know what I thought, and my son wouldn't have had a vote in that decision, but he's alive today because I put my 2 penneth in. Sorry to sound sanctimonious, but that's what it boils down to.
I mean, it does sound a little bit sanctimonious, and I think in this instance, I can totally understand why you would feel very, very worried about home birth. I think that's completely understandable. But these are guidelines from NICE, as you say. These are not made by some small organisation. They're not based on feelings. They're based on evidence, and we have to return to the evidence and trust that women are sensible enough to make judgments that are best for them and best for their families. These decisions have to remain in the hands of women. It's essential.
Daghni, is it just for women to decide on this? Are we all worshipping at the great altar of choice?
Well, the choice is an important agenda. I think what is more important is to examine the evidence out there. Birthplace study, which is a study that has now given us a good evidence base on where it is safe to have your baby, has provided that evidence. It's always emotive and really difficult to talk about individual cases and individual experiences.
But it gets more difficult if half the population is ruled out from having a view, as Rebecca seems to urge upon us.
No, I absolutely think that both the woman and her partner are important decision makers, and I'm keen to emphasise that it's the experience of the woman and her family that is important, and that needs to be taken into account. Obviously, ultimately, the decision lies with the woman as to where she chooses to have her birth, but hopefully that will be with a lot of information and a fair bit of evidence and support to support her choice.
Does cost come into this at all, Daghni? Which is more expensive, home birth or in a hospital?
Well, it's not just the cost of the place of birth, it's the whole pregnancy. So a woman who goes through pregnancy with the least possible intervention is most cost effective. What we're in the business for is to make it a safe experience, to make it a positive experience for women and their families. And that is not always, it can't always be measured in terms of pounds and pence. But cost does come into it in terms of human resources. So we still, unfortunately, have a shortage of midwives in this country. At a home birth, generally there are 2 midwives required. Even if the woman chooses to, sometimes that is not available, it's not possible. And we should be focusing our attentions on ensuring that we have the skill base there, so experienced midwives who are confident and happy delivering at home on a midwifery-led unit, being available at the right time, at the right place.
Yeah, Rebecca, what do you say to those people who argue that we've got this sort of cult of midwifery, that midwives have made this a campaign which they cleave to, that they want to force through in the face of some medical evidence? I mean, passions do run very high on this subject. We're aware of that. What's your sense of where this debate now goes? Have we heard the last word on this thanks to NICE's intervention? Is it case closed?
I don't think it's case closed until commissioners have ensured that we have a maternity service that really genuinely is fit for purpose, that we have enough midwives, that our midwives and doctors are trained to give the kind of individualised, respectful, compassionate care that NICE talks about, but also that we have services available for women who want to birth at home, who want to use midwife-led units, and that we have enough services available for women who want to be in obstetric units, and that those women aren't giving birth in substandard facilities, that they also have access to the same tools and facilities to have the best and most positive experience of birth. So this is really about just making sure that every woman has a voice. And as Daghni said, in her context, she will be working out with her family what is best for them. But ultimately, it is about her having the most positive experience through that pregnancy and birth. We know that giving birth in the UK is incredibly safe. We now just have to make sure that commissioners make the services available to women in the UK so that they can make a decision about what is best for them.
OK, is it an experience or is it a life or death decision? Opinions vary. Clearly, we've illustrated that. Fiona Sullivan emails in to say, I've had 5 children, 3 at home, 3 home births, 1 at a birthing centre, 1 in hospital. I would always choose home births unless told my baby or I were at medical risk. This email from Margaret Orme in the 60s. I had all 3 of my children at home with a midwife. It was the norm. Only in emergency did you have a hospital birth. What, I wonder, though, were the child mortality figures back then? We've also had this from Lorna, who said, I had a home birth in 1971 and hemorrhaged. I had to be rushed to hospital for a life-saving operation. I'd tell every woman, never have, never have your baby at home. It's horrendous when it goes wrong. Let's just wrap up this if we can and tackle that final email. Rebecca, what do you say to a correspondent, the likes of which we just heard from, who said, look, this is all fine. It's all fine playing up the importance of a positive experience. But this isn't about an experience. It's not just another box to tick off from the things you have to do in the course of your life. This is literally a matter of life and death for the mother, potentially, for the baby, potentially, who doesn't get a vote in all this. You know, what's the direction of travel? Where's this debate going, do you think?
I think it's very clear from the evidence from the Birthplace in England study that's quoted here in NICE that giving birth in the UK is a very safe thing to do. And actually what this guidance is trying to do is to make it safer. And by safety, we have to make sure that we are absolutely considering the life and death aspect that you're talking about there. Where is going to be safest for that woman to give birth? However, women define safety a little bit more broadly than that. The impact of a very, very traumatic birth can last for an incredibly long time. These are not small, insignificant experiences in a woman's life. You have to remember that it's only 5 or 6 years ago that suicide was one of the leading causes of maternal death in the UK. We are looking at safety broadly. It has to be physically safe, and it also has to be culturally and emotionally safe where a woman gives birth. We're doing very well on physically safe at the moment. I hope that these NICE guidelines make it more likely that we will be commissioning services that will make birth more culturally safe, more emotionally safe for women, as well as keeping physical safety of mother and baby an absolute top priority.
And Dr. Rajasingam, you know, we get a sense that amid the midwifery community, if I can put it that way, the decision's been taken. Midwives know where they stand on this. Within obstetrics, amongst the consultants you rub shoulders with, how divided are they? Or is there a degree of unity? Is there an evolving picture? Is the understanding that we're moving in a given direction? Where do you stand? You know, how unified is that body of opinion?
As a member of the Royal College of Obstetricians and Gynecologists, I can speak for many of my colleagues when I want to emphasise the fact that providing safe, effective and a positive experience for women is a team sport. It takes midwives, it takes obstetricians, it takes the scores of other healthcare professionals to risk stratify those women, to keep them safe, both in the antenatal period, during their time at delivery, and then just as importantly, after they've had the baby. And we mustn't lose sight of that.
Just had a text from Dr. Ellie Cannon, who's a regular on this channel, GP. This debate comes around every few months, every 9 months, says Dr. Ellie Cannon. Daghni, Rebecca, thanks both very much indeed for your thoughts today. As ever, it's a tender subject. Jane.
Well, this is Sky News. Coming up after the break, all the business news, including some good news for consumers, how the price of food could be going down this Christmas.